this sessions case-based to make it interactive, and that is what gives you a real opportunity to learn from your seniors that what do they do and how do they decide in difficult situations, how do they make their clinical decisions as the cases progresses, as the diagnosis and management decisions have to be made. So this year our focus is pancreatic diseases, and we have prepared 4 actual cases during which we will go through the different stages of the disease, and then our panel of experts will highlight how to make the right decisions and how to make the right judgment about the patient's condition and the management to be followed. So I hope this will be a good learning experience, and we are all going to learn a lot today, and thank you very much.
Thank you, Professor Shahid, for such beautiful remarks. Now we will quickly move to the case 1. The case 1, we have expert panelists. I will request Professor Abul Fazal Ali Khan, please come on the stage and have a seat, sir. Professor Abul Fazal Ali Khan, he is the Dean of Surgery Division, Rashid Latif Medical College. He formerly has been a professor of surgery in Jinnah Hospital, Lahore. So welcome back home, sir. The second name, which I'm going to call, I don't think he needs any introduction. You name the procedure, he has done it. And he has established a beautiful department and a very efficient team in Lahore General Hospital. So I'm requesting Professor Nabi Tayab to please come on the stage. Professor Nabi Tayab has worked very hard to establish gastroenterology department in the public sector, sir. We welcome you, sir, and we feel honored to have your presence, sir. Now I request Professor Haroon Yousaf Saab to please come on the stage. Professor Haroon Yousaf, he is the Professor of Medicine and Head of Gastroenterology Division in Shalamar Hospital. Now I request Professor Kashif Malik Saab to please come on the stage. He is the Head of Department and Dean of Gastroenterology and Hepatology Division in Sheikh Zayed Hospital, Lahore, sir. We welcome all of you, sir. Thank you. And now I request Professor Tahir Bashir to please come on the stage and have a seat. Professor Tahir Bashir is the Professor of Medicine in Jinnah Hospital, Lahore. I will request Professor Dr Sadaf Arooj to please come on the stage and have a seat. She is the Professor of Radiology in Jinnah Hospital, Lahore. Last but not the least in this panel, we request Dr Shafqat. He is the Associate Professor of Gastroenterology and Hepatology, and he is from Lahore General Hospital. So we welcome all of you, sir. The presenter of this case is Hafiz Irfan. He is the Senior Registrar, Gastroenterology in Lahore General Hospital. And the moderator of this session is Dr. Zoha Rahim. She is the Assistant Professor of Gastroenterology in Jinnah Hospital. Dr. Zoha, please come on the stage and start this session, please. Thank you.
Thank you, Dr. Awais. Assalamu alaikum. Good morning, everyone. I would like to welcome our worthy panel of experts and our respected audience. We're looking forward for a highly informative and interactive session today. Thank you. Dr. Irfan, will you please start with the presentation?
Thank you very much, Dr. Awais, Dr. Zoha, and thank you very much, Professor Dr. Shahi Sarwar and his team for providing this platform. So let's start with today's first case. So the case history of this patient: the 37-year-old male, married with 3 kids, occasional smoker, no history of any comorbids, having a history of epigastric pain that is radiating to back from last 1 day, and pain associated with vomiting, and labs showing hemoglobin 17.6 with the raised TLC count and raised amylase and lipase levels, and the transaminitis. Ultrasound abdomen that was showing multiple stones in the gallbladder, collectively measured in 15 mm. CBD was dilated with the 6 mm stone noted causing obstruction in the proximal CBD, and all the liver and spleen were normal. This is the former report of his ultrasound abdomen. So, Dr. Zoha?
I would like to request Professor Dr. Tahir Bashir, what is your experience in management of such patients? What is the initial management steps? Can you please guide us and our audience? Thank you.
Whenever we are encountering acute pancreatitis, first of all, when the patient comes to the hospital emergency, we need to assess what's the severity of the pancreatitis. In cases of mild pancreatitis, which is usually managed at the ward levels, the problem occurs in the patients who are suffering from moderately severe or severe category pancreatitis. Ideally, such patients must be taken to the intensive care department firstly. Then, if we talk about the severity, there are different criteria which are used to assess the patient's severity, particularly at the admission and at 48 hours after the admission. They help a lot, I feel, most of the time. The bedside severity index is very good at it, and we have been using that. Or once we assess the severity and the patient is in the intensive care, the next most important step comes the rehydration. Initially, it was thought that that's very aggressive fluid management, up to even 400, 500 mils per hour. But with the passage of time, we are going to conclude it's more like a dynamic fluid management. It seems to me very likely to be the management of the critical phase of DHF, as we have been doing it. So usually we prefer, if the patient is having shock or organ failure, in such situations we can give a bolus of almost 10 ml per kg per hour, strat bolus, or afterwards we can give safely 1.5, 2 ml per kg per hour. And then we need to titrate it according to the urine output, particularly after 48 hours of admission. If the urine output is coming up, then we can think about reviewing. Most of the time, if we aggressively give the fluids, there is a very much chance of fluid overload. So neither we need to keep the patients dehydrated, nor we have to flood the patient with the fluids. As the ischemia worsens, necrotizing pancreatitis incidence increases in not giving the fluids, or if the urine output is not coming after 48 hours, then there is a chance of acute tubular necrosis. So if you are giving more and more fluids and the urine outputs are not coming up, so you need to review the fluids. So you have to give a dynamic fluid therapy, and you have to control effectively, obviously, the pain of the patient with narcotic analgesics. And then you can proceed further and think about the management further. You can also look for the hematocrits and other parameters as well. This is very important for the doctor to effectively manage the patient in first 24 hours. Thank you.
Thank you so much, Dr. Tahir. Yes, Professor Abul Fazal.
I think for the benefit of PGRs, as rightly pointed out, the initial management is fluid resuscitation. But we should also define the endpoints of fluid resuscitation. So endpoint can be the hemodynamic parameters, but these are very gross. And has been rightly pointed out that in cases of compromise of cardiac function and renal function, we should be careful with the amount of fluid that we give. So the shock is defined as lack of oxygenation of cells. And the endpoints are actually to determine the serum lactate level. Once you have stabilized hemodynamically, your patient at cellular level is resuscitated when his bicarbonate level and his lactate levels are within the normal range.
Thank you, sir.
I think my worthy colleagues have raised very important points in the management of acute pancreatitis, but I'd just like to raise a few controversial things. In terms of fluid management, we have the waterfall trial, which has very clearly highlighted how much fluid to be given. But looking at the practicality of the things in Pakistan, I think first thing first, in Pakistan scenario, we have to decide whether acute pancreatitis is a surgical emergency or a medical emergency. I understand that there are people from almost all the hospitals of the city and from the neighboring cities as well. And using this forum, I think we need to decide and we need to give a strong message to the administration and to our colleagues whether acute pancreatitis should be managed by the medical team or by the surgical team. The word experience is here with us. There are the centers in the world where acute pancreatitis has been dealt by the surgeons. Now there are centers where acute pancreatitis is dealt by the pancreatic team. I understand that in most of the Pakistan ERs, the surgical departments are chaotic. Now, medical team is there, gastroenterology team is most of the time not first on call, they're second on call. The dedicated team concept of pancreas and the GI bleed is not existent barring few hospitals. So maybe at this forum I shall like to have the opinion of my colleagues. What is their opinion in terms of whether the pancreatitis, acute pancreatitis, should be managed by the surgical team or by the medical team? When it's to be managed by the medical team, we know that we have a good experience in managing dengue shock syndrome, we have good experience in managing acute gastroenteritis arising of acute severe gastroenteritis. And we have a bigger medical team sitting in the ER. So why not by the medical team? Why is it so that in majority of the hospitals it is being managed by the surgical colleagues, where most of the time on the floor, the majority surgical team is sitting in the OR, while on the floor, usually there's one house officer and one PG is providing the service. I'm not blaming them. It's not that I'm criticizing them or I'm trying to be negative about them. I'm talking about the ground reality. For every patient, one has to individualize the management. There's nothing like hard and fast. Professor Abul Fazal has very rightly said that we need to look at the endpoints. And the endpoints are obviously, aankhein band karke, usually for example, in this case where hemoglobin is 17.6, and there's a clear evidence of acute pancreatitis. My message to my team is always, aankhein band karke 1 liter fluid running में दे दो, उसके बाद 120 ml पर के हिसाब से बता दो, सिर्फ ये बता दो एज कितनी है. Ischemic heart disease, renal failure का पुराना patient तो नहीं है. If it's that not the case, this is the standard treatment that I follow. So, what is the opinion of the House in terms of acute pancreatitis being a surgical management dilemma or medical management dilemma? And I understand that there will be people who will be taking a diplomatic view. It should be a multidisciplinary management. Multidisciplinary management in ER, yes, it is possible. Most of the time, we are working with the load that's there in the ER.
Anyone would like to comment on this?
I think it should be, I agree with Ghiyas, but there's a lot of problem in deciding whether surgical team, because it's an acute abdominal most of the time. So, but it should be a multidisciplinary approach, and initial assessment should be done by either the gastroenterology team or the medicine team. And in this patient, I think there's a big controversial thing is there, that there's a stone in the CVD, and we have to assess whether that stone is causing obstruction, that stone is causing any cholangitis in this patient or not, and whether to plan ERCP in this patient or not. The guideline says that we should delay the ERCP as because an invasive procedure it has own complication, and because most of the stone, about more than 80-90% stone passes into the rhythm by itself. So,
Haroon, may I interrupt you? In how many ER departments of public health, public hospitals, we have the facility of ERCP available?
Yeah, I think very few, no doubt in that. So I don't think a ERCP should be the first choice in such patients, because my experience and most of our colleagues' experience is that that stone passes by itself in most of the time, and very few a time it is impacted in the
surgical medicine. That should be a clear.
I think with more and more intervention of gastroenterology invasive procedure with reference to the complications of pancreatitis that we are dealing with. So it is more of a domain of medicine and gastroenterology now. And surgeon will agree that the surgical intervention, the number of procedures that they used to do 5 years ago and now are significantly decreased with more and more intervention of endoscopic procedures. So वो तो सर पेशेंट जहाँ एडमिट हो जाएगा फिर वही चलता रहता है ना. So scene has to be made at that time.
नहीं सर, बात ये है कि as Dr. Ghiyas mentioned, previously 25 years back when I went to Koita first time, all the pancreatitis patients were admitted in the surgical ward and they have to call us and something like. But now when we have the interventions, we want to, and even the surgeon want to delay the surgery. I think this is the primary domain of a physician, especially gastroenterologist, to deal with this. Along with that, as multidisciplinary, take the surgical team on board. Primarily, my vote is that it should be dealt in the medicine department and in medicine, if preferably in the gastroenterology department, because as you mentioned, the HB is high, the house officer or the resident will not be able to calculate the fluid requirement of this patient. As you said, in surgery, they are busy in ORs and all the things. So what we have to do is, we have to take the patient to the medicine along and take the surgical team on board, because if this is acute abdomen and things like that, then you need the surgeons at any time. So that is my viewpoint for this.
Thank you so
If
much.
it's a HDO, double IV line, preferably CVP line, quick rehydration, that's fine. But the message that I want to give to the community, and the point, the reason that I want to raise a point, that still in majority of the public hospitals, it is dealt, it's a dilemma. Acute pancreatitis, does it have to go to the surgical ER or the medical ER? We have the luxury of having Professor Abul Fazal, the teacher of the teachers. So let's have his opinion.
Okay, there is no doubt that the management of acute pancreatitis is mainly medical and supportive. But all acute abdomens need to be evaluated by the surgeon. And raised serum amylase does not exclude surgical emergencies needing urgent surgical intervention. So whosoever manages a diagnosed case of acute pancreatitis depends upon the logistics and the flow of the patient and the availability of staff. And I think it should be institutional based. But single serum amylase coming high with pain abdomen, surgical consultation is mandatory. And that is my point of view.
Thank you so much. Dr. Irfan, can you please
Thank you
move
very
on
much,
to
sir.
Next slide.
Change screen.
as
So
Professor-
the patient was admitted in ICU and given IV fluids and analgesics, but patient developed high-grade fever up to 106 degree Fahrenheit. So ERCP was done. Cholangiogram showed proximal CBD negative shadows. Sphincterotomy done, followed by balloon sweep, resulted in stone extraction. 7 fronts, 10 centimeter stent was placed in CBD.
I would request Professor Dr. Kashif Malik, what is your experience about the choice of antibiotics? When should we switch to a broader spectrum antibiotic, as the ERCP is done but the pain is and fever is not settled?
This is a very tricky question. Actually, with the choice of antibiotics, we usually use carbapenem is the first line of treatment for in our setup, because the penetration to the pancreatic tissue with the carbapenem is excellent. So other antibiotics broad spectrum can be given, but to start with, even we do not go with ceftriaxone if the patient is having acute pancreatitis with cholangitis, and along with that, this kind of obstructive jaundice. So my preference will be to start with carbapenem and full dose, not like this 500 milligram TDS and all like this. Imipenem or meropenem are the best drugs for these patients, and then you can switch to the other drugs depending upon the condition of the patient.
But sir, generally you don't recommend starting antibiotics with acute pancreatitis. So when do you decide that now it is essential?
If the patient is in sepsis, the patient like in this patient is having cholangitis, patient is having high TLC, I think this is better to start the antibiotic from the beginning, because you are very right, in acute pancreatitis, if there is no sepsis and it's just inflammation, the antibiotic should be avoided in the patients having acute pancreatitis.
Because TLC,
I think I shall like to again आज के दिन मुझे लगता है कि मेरी जॉब है कंट्रोवर्सी create address करना या उसको point out करना. Now Professor Kashif has said sepsis. What evidence do we have in this case that this patient got sepsis? There's no fever. There's no fever. Yes, WBC count is high. Patient does have gallstones. Patient does have evidence of stone in the bile duct, but raised WBC can be an acute phase reactant as well, and that is really the case. So, although the guidelines say no antibiotics, but in real life, the moment the patient lands in the ER, one antibiotic gets administered for one reason or another, either by a junior person or by a senior person, and you keep hitting the wall. क्यों भाई एंटीबायोटिक क्यों स्टार्ट किए, कौन सा इन्फेक्शन है? But then the ground reality is that in each and every patient we are going straight to imipenem or meropenems. Is it the right approach or is it a wrong approach? Personally, I'm an antibiotic person, but then looking all around, I see people using antibiotics so frequently and so liberally that it makes me wonder that down the road 2 or 3 years later, or maybe 5 years later, where are we going to end up in? In this case, do we have any evidence in terms of infection first and then leading to sepsis? To satisfy that the person has got sepsis, Professor Abul Fazal has rightly said that you need to have endpoints. You need to have look at the parameters confirming that this person does have sepsis, procalcitonin, or maybe the clinical parameters on the basis of which we diagnose sepsis. Are they there in this patient? Systemic inflammatory response syndrome occurs in any acute inflammatory condition, and pancreas is the one in which the systemic inflammatory response syndrome occurs in its most worst form.
As Dr. Abul Fazal mentioned, these patients usually, the initial diagnosis is acute abdomen. So this is a practice to start with antibiotics in these patients when patient present to the emergency. So that is the ground reality. You are very right. If the patient is clearly diagnosed and having acute pancreatitis, no other signs of antibiotics, then it can be reconsidered that one should not start with antibiotics. But usually the practice is when the patient comes to us, usually that they have visited 2 or 3 local hospitals and all that. If we do not start the antibiotics at the first stage, we may end up with some complications like this.
But sir, precisely जिस वजह से antibiotics discourage किए जाते हैं for promoting resistance, that is a big problem in our community, because for us, apart from Maronam, no antibiotic works in any sort of infection.
Yeah.
So probably the message should be to avoid antibiotics, because TLC count high, fever, all these can just be a feature of any acute pancreatitis without any evidence of sepsis.
Yeah, and I think we should avoid, because initially the pancreatitis is a sterile condition. There's no infection in it. And if you want to assess the infection, whether this TLC is raised or fever is because of infection or because of inflammatory response, do procalcitonin at day 4 and day 7. And if that is raised, and now people say the threshold is 1. If it is more than 1, then think about starting with antibiotic. In this case, I think one invasive procedure was done, and that is ERCP, and that may be the reason to start a broad spectrum antibiotic afterwards.
Akif, biliary pancreatitis typically and historically gives rise to see head of the inflammation of the head of the pancreas, not body and tail.
Professor,
So adding on this issue of antibiotics in acute pancreatitis, there's also a concept of timelines when we prescribe antibiotics. There is some data on the initial part of the pancreatitis, like in first week, there's very less chance that the patient may be having, even if the patient is having necrotizing pancreatitis, infection of that necrosis is less likely. There is some data in the initial week, most of the patient, if there is infection, it is usually extrapancreatic infection made in the form of cholangitis, UTI, pneumonia. These patients are prone to have other infections too. And if the patient is in the second week or beyond second week, and then there is deterioration, and if there is a new onset, any organ failure or progressive organ failure, these are the patients where, as per guidelines, we should consider antibiotics. Antibiotics should not be given in each and every patient because systemic inflammatory response, fever will be having in many of the patients.
okay, thank you, sir. Professor Dr. Kashif, can you please tell us what is your experience regarding early versus late ERCP in such patients? As you can see, we went for an early ERCP, like within 24 hours.
Again, a controversial topic. So, what we face is that sometimes patient comes to us late. The literature supports the early ERCPs in these patients, but the diagnosis is very much important. As Dr. Haroon mentioned, sometimes there is a sludge and something like that which passes itself. So going for a intervention at early stage may end up with worsening of the acute pancreatitis. But in a patient, he is having sepsis, a patient is having clear-cut diagnosis of impacted CBD stones, and the patient otherwise is okay. I think even the patient, if not in sepsis but is in pancreatitis, early ERCP will help to clear the CBD and to minimize the complications of acute pancreatitis.
Thank you, sir. Dr. Irfan?
फिर मैं कंट्रोवर्सी जनरेट करता हूँ कि यार ERCP रिपोर्ट में कहते हैं एम्पुला इज नॉर्मल, CBD is normal, no stone. Ultrasound कहता है कि there is a significant dilatation of the CBD with a 6 millimeter stone. Now, has that stone gone back to the gallbladder, or has it got passed? And if it is passed, how is it possible that ampulla is normal?
So no, as Dr. Haroon already mentioned, the stones comes impacted in the ampulla. We give the painkiller. The injured knee, then it will be a sludge ball. That is the thing, because not every time there is a stone it can cause impaction. This may be sludge ball. Controversy. So, and the second thing is, if we have clear-cut evidence that these are gallstones also, and patient is young, I think early ERCP may help in the management of these patients.
Okay, thank you, sir. Dr. Irfan, can you please move to the next slide?
Please change the view. So patient was admitted in ICU and given IV fluids and analgesics, but the patient developed high-grade fever up to 106 degree Fahrenheit, and the pain was not relieved with analgesics, and infusion started with tramol and morphine given SOS. After 48 hours, symptoms didn't improve, so CT abdomen was planned. So please play CT images.
I would request Dr. Sadaf Arooj to please comment on the CT images.
Professor Ghiyas, I think there was one more point, that why was the stent placed? Why was the stent placed when the stone was removed, CBD was clear? So this is I think another discussion point.
मेरे abundance of caution है कि maybe उससे सोचा हो कि gallbladder से मज़ीद stones, क्योंकि ultrasound पे gall stones लिखे हुए हैं, तो maybe मज़ीद stones उतर के नीचे ना आ जाए. That's the only explanation that we can give. Otherwise, the ultrasound report and ERCP report doesn't seem to match with each other.
So this is CT scan of the patient, and this is a post contrast. Here we can see these are the images of the lower thorax. This is right-sided pleural effusion and left-sided pleural effusion. Here when we look at the pancreas, most of the pancreas remains non-enhancing, and we cannot appreciate a pancreatic tissue in most of the pancreas anatomical location. So this is pancreatic necrosis, and if you look around the pancreas, the whole thing appears very much edematous as well as inflamed. Here, in this, if you can see, this is the lesser sac, and the fluid collection is present anterior to the pancreatic tail and just behind the stomach. This is around 80 to 90 ml. Another point that I would like to show here, there are multiple small filling defects in the venous system. This is portal vein. Here we can see there is a small filling defect. This means a thrombus, and other thrombus in the splenic vein. Multiple other small thrombi are also seen in the superior mesenteric vein. The inflammation and the fluid collections are continuing into the paracolic gutters and into the pelvis. The gallbladder is full of contrast because this was done post ERCP. So this is the contrast in the gallbladder. Here we can see the stent, biliary stent. It is in situ, as we can see small amount of air in the intrahepatic bile ducts. On the basis of this CT scan, I think this is a severe form of the pancreatitis, and this is a necrotizing pancreatitis.
Okay, thank you so much, ma'am. Dr. Irfan, can you please
change.
slide?
So this was the CT scan of this patient that was showing necrotizing pancreatitis with the CT severity index of 10. This was the former report of CT scan. So patient was managed with the analgesics, IV fluids and antibiotics for 7 days, and pain and fever didn't settle. Examination showing a slightly tender abdomen with the bowel sounds audible.
Skip to the next slide.
Okay. Abdominal ultrasound that was again repeated showing enlarged pancreas.
सिर्फ एक मिनट यहाँ पे तो यहाँ पे ना एक मैसेज मैं अबुल फजल साहब देना चाहते हैं, जैसे अभी प्रोफेसर रेडियोलॉजी ने बहुत एक क्लियरली हमें चीज़ शो की है कि देयर इज थ्रोम्बस इन दी स्प्लेनिक वेन, देयर इज थ्रोम्बस इन दी पोर्टल वेन. तो माय रिक्वेस्ट टू ऑल माय कोलीग्स इज दैट एक वो होता है इमरजेंसी में बच्चा भी जूनियर है, वहाँ पे फैसिलिटी भी नहीं है, सीटी स्कैन इस तरह लगा के देखने की कोशिश करें. My humble request to all, please take the CD and go to the radiologist. Radiology department is available round the clock. Go to them, sit with them, and have a look at the anatomy. Go through the anatomy yourself with them, so that you may be able to satisfy the parameters. For example, in this patient, Professor Arooj has very pertinently mentioned that the collections are there, the fluid is there in the pleural sac. Fluid is there around the pancreas, fluid is there in the flanks, and then striking towards the pelvis as well. Meaning by that she is, in the technical words, conveyed to you that it is extensive necrosis. Secondly, the most important thing that she's mentioned, thrombus in the venous system. Now this should put an alert to all concerned that this is not a simple acute pancreatitis, it is acute severe necrotizing pancreatitis with acute necrotic collections. So you want to say something?
I think one thing which is very important for me, and that has not been mentioned, is how do we support these patients nutritionally. And as we know, there's a strong metabolic response to injury, and these patients are in catabolism. The traditional way of managing acute pancreatitis is to keep them nil parorum till further orders, with a view that they want to give rest to the pancreas. I think this is not based on any fact. Early enteral nutrition is important, and in cases where there is severe metabolic response, immune modulating and nutritional support does help.
Thank you, sir.
So thank you very much, sir. Very well.
Here, to Ghiyas and Kashif, what is the place of anticoagulants and octreotide in the initial management of acute pancreatitis, moderate to severe?
The octreotide, we don't have any analysis, meta-analysis to support the benefit. But for anticoagulants, in a patient like this, acute severe necrotizing pancreatitis with evidence of clot in the SMV and in the splenic vein and portal vein, straight away, right away.
Thank you so much, sir.
So this nutritional part is often the neglected part in the management of acute pancreatitis, and there's good evidence, and all the guidelines recommend that nutritional assessment and the way of nutrition should be evaluated beyond first 24 hours. And the preferred mode of nutrition is enteral nutrition, and NG is equal to NJ. But if in a subset of patients may be having gastroduodenal obstruction, in such cases where they may not be tolerating NG feed, in such cases may be needing NJ feed.
Thank you, sir.
So ultrasound abdomen that was repeated, showing enlarged pancreas with having a collection of 6 into 2.7 into 9.8 centimeter in the pancreatic body. Another collection of 9.9 into 4.2 centimeter in the pancreatic tail. This was the former report. MDM discussion was done. That was going for EUS guided intervention. So EUS guided cystogastrostomy done, collection was drained, and sample was sent for culture sensitivity. But there was a bleeding that was developed while performing EUS guided cystogastrostomy.
I would like to
Controversy.
request Professor Dr. Ghiyas.
Why did MDM decide to go for, on what parameters MDM decide to go for drainage? Did the patient have significant fever?
Sir, the
or
fever,
refractory symptoms of persistent vomiting?
So patient underwent ERCP, which is an intervention, but the pain and fever did not settle, and the patient was having a high-grade fever of 106 Fahrenheit. So they planned cystogastrostomy.
So at that time, CT scan, did it show any air in the cavity?
No, after CT,
you see, abscess, if we are diagnosing abscess,
yes, sir.
abscess is a different ball game altogether. We are talking about complications of acute pancreatitis. So acute necrotic cavity, you see, the reason that I'm picking up these controversies is that we have to convey to the younger audience clearly that acute necrotic cavity is a different ball game. Abscess is a different thing. Absence, do we have air in the fluid cyst, or it's different? Fazal.
I agree. I have same feeling. I'm not sure why this patient had EOS guided drainage at this stage. So usually if patient is paraxial, as we already have discussed that fever can be coming from aseptic necrosis, and best way forward is to get them cultures. And if your suspicion of infection is very high, especially if PCT is high and you're waiting for cultures, only then you can start prophylactic antibiotics, one. Number two, usual indication of drainage, peripancreatic collections is if there is an evidence of abscess formation in the form of gas, gas inside the cavity, as Professor Ghiyas mentioned. And when there is associated at least single organ failure, such as renal failure, respiratory failure, then that is a strong indication to do EUS guided drainage. Otherwise, what potentially we can do is we can convert an aseptic fluid collection by doing US cardiac drainage to a septic collection, we can very easily introduce infection by doing that. So I think that needs to be clarified.
So if we are 2 weeks down the road and we have done an ERCP and patient is still having high-grade fever, the pain is not settling, his bowel sounds are not returning. So what is the timeline when you decide to intervene? Because next step, because already we are giving meropenem, we are giving fluids. So how long we need to wait before, because cultures, in our setup, the problem is that the antibiotics are given from the day one, and most of the cultures are negative already, even if you are sending them. So you have to make the next decision. So what do you suggest? Because it's 2 weeks down.
I think generally, if there is evidence of formation of abscess, which you can pick up radiologically, I assume that is a standard indication of drainage. Otherwise, this process of necrosis itself, which can give prolonged fevers to those patients for sometimes weeks. But yes, if again is going to be patient by patient decision, and the reason we are discussing this point here is that what should be a clear indication of drainage. So in general, if there is peripancreatic fluid collection and there is no clear evidence of abscess, you can wait and treat those patients based on antibiotic therapy and all that. If there is single organ or more than one organ associated dysfunction, then that's a very strong indication of drainage those collections, even if there is no abscess formation. But if you think there's 2 weeks have gone, patient is not getting better, and your clinical suspicion is very high, I think that's also a reasonable indication, if that's what you did in this patient.
Yeah. Just one thing is very typical scenario that patient is referred to radiology department for a late follow-up CT scan, and the clinicians are asking for, is there any source of sepsis, because fever is not settling. Like in this case in acute pancreatitis. So, well, air is not necessarily needed to be in a cavity to call it an abscess. There are certain other features like enhancement pattern, wall thickness, and perifocal inflammation and straining in the fat, for which we can call them that it is an infected collection or not. Air can be seen sometime in necrosis, so only air, we are not commenting that it is an abscess. Fistulous communication can also cause some air in the in short is, as Dr. Fazal said, a strong clinical suspicion and certain radiological findings, we can say that there is an infected collection which can proceed for drainage.
When we talk of the abscess, there has to be three things: worsening of the pain, number two, development of a new hectic fever, and thirdly, documentation of air. Now, air documentation is minimum before we can say that this patient has got abscess. So the reason that I pointed out, कि MDM ने किस base पर decision लिया है? That's the reason that just to generate the discussion on this particular point.
And air may be present in only a subset of patients, and air may also be there because of some fistulous communication with bowel. So that should also be kept in mind.
Okay, sir, we are short of time. Can you please guide us how to manage the bleed during cystogastrostomy? Has it ever happened to you in your setup?
देखो endoscopic ultrasound करते हैं when you are dealing with a large cyst. You can have a vessel traversing through the cyst, or you can have a vessel compressed in the gastric wall. Number of times is the gastric vessel is compressed because of the large size of the cyst. So in case that is a vessel which was compressed by the large cyst in the gastric wall, the management is usually by taking the coag rasper and coagulating right there and then. If it is within the cavity, that becomes a difficult choice. Either to go into the cavity, doing nextectomy, lavaging it extensively. But you see, it is not an easy task to do where there's a muddy fluid all around, there's necrotic fluid all around, finding a vessel over there. The best bet is to immediately call your IR colleague, because then you're dealing with a relatively bigger vessel. So calling your IR colleague and getting the vessel embolized, that's the best bet. But for gastric wall vessel, finding it at the edges of the cystogastroscopy site and coagulating with the help of coag respa, that's the best way to go.
Thank you so much, sir.
So growth obtained from the culture which revealed specimen showing Klebsiella pneumoniae, specimen 2 Enterobacter and specimen 3 Enterococcus. Antibiotics started as per culture sensitivity. Patient symptoms improved slightly and CRP trending down. However, the pain didn't settle completely. After 48 hours, patient developed high-grade fever and increase in the requirement of analgesics.
Dr. Shafqat, can you please guide us that the patient fever did not settle and the antibiotic is changed according to the culture? What should be our next step in the management?
No, it depends what were the initial EUS picture, whether it was all liquid or whether there was a necrotic part and whether the necrosis, what was the degree of necrosis, whether it was around 10%, 10 to 30% and more than 30%. More than 50% are the cases where we may be sending them to surgery. And in this particular case, if the patient is not improving, this is the case of a step of approach. In such case, there's a portal of we have a portal of entry. We have a fistula stack through the stomach where we can go in and do necrosectomy. During necrosectomy, we do 3 important steps. One is debridement, other is extraction, and the third is irrigation. We can use standard scope, you can go with the therapeutic scope. If there was a plastic stent, we may need to dilate the tract with like 15 millimeter and then go in and do necrosectomy. And if there was a metal stent like lamps, that was the case in such case, we can go in and do necrosectomy in the same session. But there is always a risk of stent dislodgement, and we usually go in like 24 to 48 hours after if the patient is not improving. And different gadgets can be used. We can use snare. We can use different forceps like grasping forceps, alligator forceps, rod snare, tripod. But our go-to gadget is snare. We can debride. We can grasp and bit by bit we can remove such pieces, but it's a very laborious task. It can take, we usually do like 40 minutes. Ghiyas always tell when to stop, but when the progress is good, we always try to do like 1 hour session, and then we can always go in and do another session. And then there are certain newer gadgets in this area. We can like availability of endorotor where there's a cutting blade and you can under vision you can cut, debride and suck in the same. It eases. There's data that it decreases the number of sessions required. And then there's a new device from Vesco with the name of excavator. It can be mounted on the scope, and the opening diameter is around 3 centimeters, so you can get good chunk and you can go in, grab a big chunk and drop in the stomach.
मैं क्या चीज़ सिंपल कर दूँ, शफकत ने वाइस का जो recent lecture पूरा सुना दिया. चीज़ ये कि patient has got issue is patient has got non-resolving fever. Clearly that indicates कि cystogastroscopy का मतलब ये नहीं कि जितना गंद अंदर है, कीचड़ है, गटर में वो सब बाहर आ गया. That means that still there are undrained pockets somewhere in the tummy. So that means कि आप surgeon और surgeon और radiologist का बैठ के एक दफ़ा दोबारा CT scan देखें, कोई ना कोई undrained area है which needs draining, and that's the reason that we need to involve. We need to have a good surgeon which can go in retroperitoneally and drain the collections which are there in the pelvic gutters and the pelvic area, and that's what we were discussing just before the thing. To cut things simple, another CT scan. If patient is not getting better, another CT scan. Sit with the surgeon and sit with the radiologist.
So, Professor Dr. Abul Fazal, can you please guide us that is surgical intervention helpful or endoscopic necrosectomy is enough in this patient?
Okay. Yes, you can dispense away with surgeons in the initial management of pancreatitis, but the role of surgery remains. Now this patient has settled, but cholecystectomy still needs to be done, and that is one thing. If it is interstitial pancreatitis, we do it in the same admission, but in these complex cases, we let the patient recover and to prevent recurrent pancreatitis, we must do cholecystectomy. The other thing is that you can drain the fluid, but the necrotic pancreas has to be removed. Otherwise, again, the fluid will form. Now, I've seen very good videos of shafqat removing necrosed pancreas through endoscopy, and that is, I think, the best thing to do without any cut. But when this is not available, the equipment or facilities, video-assisted retroperitoneal drainage is the route to adopt. Transperitoneal intervention leads to disasters. It leads to more complications than the problem you had initially, and it will lead to laparotomy as a first resort can be disastrous. So yes, surgery, but it should be video assisted or through a reasonable hole. Go retroperitoneally. Don't transgress the peritoneum, then you will have problems.
Thank you so much, sir. Doctor.
And another thing that you can do in such cases, if on the initial EUS drainage you see there is a lot of necrotic debris, you can always put in a nasocystic tube, and patient may be kept on continuous irrigation. That helps. Number of sessions for necrosectomy may be less and may not be required at all.
So necrosectomy was done. This was the video of necrosectomy. Please play the video. Okay. You can see the snare passed through the stent, and the pus was coming out, and a lot of necrotic debris was there, over there. This was the procedure that was done as explained by Dr. Shafqat.
एक चीज़ मैं बता दूं कि एवरेज सेशन नेक्रोसेक्टमी का दैट यूजुअली लास्ट फॉर 90 मिनट्स टू 120 मिनट्स. इतना ये क्विक नहीं होता. इट टेक्स टाइम.
So a lot of necrotic debris was removed. After that, cavity was flushed with normal saline and gentamicin solution. So patient improved clinically after necrosectomy, and symptoms were improved. Follow-up ultrasound and CT abdomen was done. And you can see in the labs TLC count trending down 8.5 with the normal amylase and lipase levels, hemoglobin 13.9. So follow-up CT was done.
Dr. Sadaf, I would request you to please give a quick review of the CT.
You can see this is the portion of the lower thoracic CT scan. Here we can see that the right side effusion has been resolved in this case, and there is small effusion on the left side. This is the tubing, the gastrocystostomy tube, and the whole fluid collection which was present in the lesser sag has diminished. And if you look at the paracolic gutters and overall the situation of the abdominal cavity, the fluid has been resolved. Most of the inflammation has settled.
Thank you so much, ma'am.
अब कंट्रोवर्सी ये है कि गॉलब्लैडर में स्टोन नहीं है, कोलेस्टेक्टमी करनी है नहीं करनी. Although we have history that patient did have stones in the gallbladder, अब gallstones किधर निकले?
Okay, so the recommendations are that if it is not alcoholic pancreatitis, or if there is no other cause of pancreatitis which is evident, even in the absence of demonstrable gallstones, prophylactic cholecystectomy should be done.
Thank you, sir.
Now the things are changed now because we have another problem with autoimmune pancreatitis and things like that, with the LFTs are deranged, but the gallbladder is clear of any stone. Again, we stuck up that we should go with the cholecystectomy in these patients or not, because we are afraid that if this is biliary, then we have to go with the cholecystectomy. But if it's autoimmune or other causes, then again we will not get any benefit from this cholecystectomy.
I would like to add here that gallstones, for the gallstones, the investigation of choice would remain ultrasound abdomen. Like I cannot comment upon the gallbladder stones exactly on CT scan.
The 2024 American Gastroenterologist recommendations are that if you cannot find any cause of pancreatitis, then cholecystectomy should be done.
Sir,
and that is because the stones which cause acute pancreatitis are very small, rice grain, and these may not be even picked up on ultrasound. We should not look gallstones, as Dr. Sadaf has rightly said, on CT scan. We miss a lot of gallstones. It is the ultrasound which is the investigation of choice for gallstones, but at least the stone has to be 2 to 3 millimeter to be picked up on ultrasound.
I would like to add on this. Common things are common. With the advent of EUS, I saw a recent article which showed in patients with recurrent pancreatitis, with EUS, the most common cause they found in 30% of cases were mycolithiasis. So common things are common. If the patient is having recurrent pancreatitis, go with the cholecystectomy. Yeah.
Cystectomy, or we can preserve?
देखिए चीज़ है कि it's some you see, for everything we don't have hard evidence. This is a debate and this is a dilemma that is faced. This is not just that we're facing it today. It is being faced all over the world. A person who has got normal gallbladder with history of biliary type pain and mild pancreatitis, will you go for cholecystectomy or not? Historically thinking, the recommendation is go for cholecystectomy even if it is not required on solid basis. Why? Because in 80% of cases still the cause of pancreatitis is biliary. So that's the only base, but this evidence is weak. It's not a very hard solid evidence. So all the guidelines say that with weak evidence, the recommendations go for cholecystectomy.
So another important message is, in this particular case, the cause of pancreatitis was parasitic adenoma in this particular case. So you should always look for the other causes of pancreatitis as well. And many of these patients with parasitic adenoma has only marginally raised calcium. So a high level of suspicion should be done. And in this case, parasitic adenoma was the diagnosis.
Thank you. Professor Ghiyas, can you please guide us how to follow up this patient radiologically and biochemically after the labs have settled, for the follow-up of the patient in OPD?
Follow-up of this patient.
Follow-up, देखिए, there's been intervention. We are going to leave the plastic stents for life. We are not going to take them out for the simple reason that if there's a fistula formation in the duct, so the pancreatic juice should keep draining through the stomach. That's number one. Number two, as said, no specific follow-up is required. Cholecystectomy is definitely indicated. So surgeon should go for the cholecystectomy. And once the cholecystectomy has been done, the periodic follow-up like any other person, if there's no complaint, though no specific follow-up is required and no specific guidelines available to follow these patients.
Okay, thank
So
you, sir.
in this case, LAMS was inserted. So when to remove the lamb, this is also important. Orlando team found that if you keep the stent for more than 4 weeks, the cavity collapses and then the stent rubs against the wall and there increase chances of bleeding. So Orlando protocol is you do a CT at around 3 weeks. If the cavity is collapsed and drained and patient is doing good, you will be removing lambs. And many, there's data that in patients with necrotizing pancreatitis, a good number of patients will be having disconnect pancreatic syndrome. So if we have already put in lambs, this should be exchanged with the plastic stent. And if the plastic stents were already placed in the initial procedure, we should leave them for good.
Thank you, sir. Professor Kashif, would you like to add something to the follow-up of the patient?
Follow-up basically is very important in this patient because you may end up with some other complications. So if the regular follow-up, as Shafqat mentioned, the first thing is you have to remove the lamb, and that is less than 4 weeks time. You have to remove it if the cavity is collapsed. And the other thing is, again, do the ERCP, put a pancreatic duct stent if there is a leakage there. So that is most important. And again, regular follow-up is always required in these patients for some time, not for always, but for some time.
Dr. Shafqat, I want to ask something. As you put LAMS in this patient, and you yourself mentioned that there are chances that cavity is going to collapse once necrotic material has been removed, and chances of bleed are there. Along with LAMS, would you like to put a double pigtail plastic stent straightforward, or if not, then what are the indications for that?
Yes, double pigtail stent can be placed. It acts in two ways. It prevents the collapse of cysts onto the stent. So and other is, so there may be less chances of bleeding. The other is free necrotic debris can plug the stent and block it. So there may be less chances if you put in a double pigtail stent inside the lambs.
या शफकत एक चीज़ में बताओ कि अगर डबल पेक्टेल स्टेंट डाल भी दोगे तो जो नेक्रोटिक टिश्यू है वो स्टेंट में आके तो उसने ब्लॉक करना ही करना है. सो ये भी एक जो ना खामखा वो एक एक्स्ट्रा वो जो चीज़ है. You see, we are not going to put lambs in our country in a patient who's got predominantly fluid containing cysts. We are going to put the lambs only in a patient who's got significant solid component. And when a significant solid component is there, putting in a double pigtail stent is not going to make any difference. Important thing is that either do the nephrectomy at the index time of procedure, or maybe start doing it after early 3 days after putting the lambs. And generally what we have seen is that 15 days down the road we have to remove the lambs because the necrotic tissue that start getting stuck into the lumen of the lumen opposing metal strand. At that time what we do is that we just pull out the lumen opposing metal strand and we do the nephrectomy, try to remove the necrotic tissue as much as possible, and then again place the lumen opposing metal strand just to maintain the stroma. In this case, at the last CT, there was no lambs. They removed this lambs and they replaced it with the plastic stent. Leaving the plastic stent there between the cyst and stomach, I don't know how many centers are practicing transpapillary drainage or transpapillary stent placement. At least I'm not practicing transpapillary pancreatic drainage. I just leave the stent there and go towards the pancreatic duct, what the Professor Kashif had recommended. Generally, the centers that I know of, not many people go for transpapillary drainage in these patients. They just rely on the drainage which is there between the stomach and the pancreatic, that necrotic cavity or that pseudo cyst cavity, so that if any fluid leaks, that should drain into the stomach directly.
Thank you so much.
Thank you very much, sir. So this was the end of my presentation, follow-up ultrasound, and thank you very much. Over to you, Dr. Awais.
Thank you so much. In the end, I would like to thank our panel of experts and for sharing your invaluable knowledge and expertise. We are grateful for your time and knowledge. Thank you so much.